Thank you, Alfie. So I'm going to do this way. It's like a personal journey of how we've moved from 30 years ago in Manchester to where we are today. These are my disclosures. And, I think I'm going to talk to you a bit about the history of the dermatology service in Manchester, the role of nurses, which is crucial to what we do in our Manchester team, and how the introduction of biologics has really elevated the role of nurses. And then how we're starting to look at outreach and rapid access as we move away from the more traditional standards of care, model of care, and then how we setting up the psoriasis service can actually influence research and training. But I think we should be aware that we've made huge progress in our understanding of psoriasis and thus our management of the disease, really fulfilling the criteria or the mandate of the IPC. So this is where Manchester is, just so where you're orientated. It's all in the north of England. And then the skin hospital, the dermatology centre in Manchester, is actually in Salford, which is better known around the world as where Manchester United have their football ground. But we'd like to believe that the most important organisation within Salford is not Manchester United, but the dermatology centre there. And this is what it looked like probably about 30 years ago, the dermatology centre. And I arrived in Manchester in 1994, having come from Michigan. At that time, for a population of 2.7 million people, it was a small clinical department. And there was no academic centre. And we felt it was very important to raise the profile. That's why I'd been appointed. And we decided that the real opportunity was to focus on psoriasis. And I'm going to talk to you about three aspects of what we did: service, training, and research, which is really the virtuous circle, if you like, of disease management. So let's begin with service. And when I arrived in Manchester, a close colleague was Dr. Robert Chalmers, who's I met an IPC counsellor. He's really the person who spearheaded the ICD coding for dermatology, ICD-10, and a great friend and a great expert on psoriasis. And very shortly after I arrived in 1994, Robert and I were getting numerous referrals of patients with complex psoriasis, impossible to manage them through a regular general clinic because they needed time. And we founded the psoriasis service in September 1994. It's the first psoriasis specialty service in the UK and one of the first in the world, actually. And it was funded in part by Sandoz, as they were then, now Novartis, for the first 3 years. And without that funding, this would not have got off the ground. So this began as a weekly clinic. The best treatment we had really was coal tar and dithronol and ultraviolet light and admitting people to hospital. I mean, at that time we had 44 inpatient beds, and the majority of the referrals were from colleagues. You can see there was just the 2 consultants. We had 2 trainees, and we had 2 staff nurses working with us in the clinic, which was once a week. And we realized very early on that the nurses were really being held back because they were not using their skills beyond just being allowed to apply dressings to patients. And the nurses themselves were very keen to do a lot more. And so what we did initially, and this sounds sort of crazy that we should even been doing that at that stage, was that we worked with the nurses to write protocols for prescribing of topical therapy. At that time, they couldn't do that. And there was huge pushback from the consultants that this was inappropriate for nurses to be prescribing topical therapy. We ignored what the consultants said. We knew what was the right thing to do. We got hospital approval and then national approval for nurse prescribing, initially for topical therapies. And 6 years later, we had a steadily increasing nursing support. Now had 6 nurses working with us. We now had research fellows doing PhDs and MDs working with us, trainees, registrars, still the 2 consultants, myself and Dr. Chalmers. And then we had people visiting us from around the world, both clinicians and nurses, and a clinical psychologist and a pharmacist were starting to work closely with us in the department. And at the same time, when I came to Manchester, we set up a clinical trials unit for dermatology. And this psoriasis service was really the main conduit for patients to enter studies on new biologic therapies. And that time, to 98, there were no biologic therapies available. So we were involved in all of the first studies on biologics for psoriasis. And the psoriasis service, this is how we were in 2002 when we won a national award for the dermatology team of the year. And by that time, we had been joined by Dr. Brian Kirby. You can see here, so there's myself and Dr. Chalmers, nursing staff, our psychologist here, Helen Richards, and the registrar at that time, Dr. Helen Young, who then became a consultant, and then some of the nursing staff and secretarial staff behind us. And then in 2010, we started a psoriatic arthritis clinic, a combined clinic, which Professor Warren and colleague Professor Chinoy ran from rheumatology, dermatology. And that was very helpful because we had cases which were very complex because they also had psoriatic arthritis. And what we found is that the people in rheumatology had a greater range of drugs available to them than we had with psoriasis. And there was nursing input from both rheumatology and the dermatology side. In now 2023, which is really the present day, we have a completely new building, a new setup, and the service is very big. It's still run as a weekly clinic, 50 complex patients. Now we have 6 consultant dermatologists, 3 trainees, 2 research fellows, a pharmacist and a psychologist, and 16 nurses. So it's moved from those 2 that we had at the beginning to different grades. Still, the majority of referrals are from colleagues, dermatologists, either locally or nationally. And of course, we have the biologic therapies. And as a consequence of the efficacy of biologics, we no longer have inpatient beds. So that's one of the biggest changes, that we no longer admit people to hospital for management of psoriasis. And this is really how biologics have transformed what we do. So in 2006, we had just 9 patients on biologic therapies. At the end of last year, just for psoriasis, we had about 2,500 people on biologic therapy. And if you've got that throughput of patients, you've got to have a very good nursing team to manage them. And this is our biologic service. They're dedicated nurses, fantastic. Without them, we wouldn't be able to do even half of what we do at the moment. And I'm not going to go into great details because very nicely Anne has sort of set the scene, but the patient pathway, nursing is critical at every step. So the patients are reviewed, of course, in the weekly psoriasis clinic, and then if they're suitable for biologic therapy, we refer them to the specialist nurse clinic for screening, eligibility, etc. And then they set up the biologic prescribing for those patients if it's acceptable. And they follow up the patients probably 3 out of the 4 times a year that the patients are seen. And if the patients fail screening or don't get funding approval, then they're referred back to the psoriasis clinic. But the educational aspects of nurses is crucial in this business. Interestingly, Anne mentioned about motivational interviewing because, of course, it's not just a matter of getting patients on the right medicine, biologics, it's also the education about lifestyle management, losing weight, stopping smoking, more exercise, better diet. The nursing team are very good at doing this. They're much better than the physicians. And motivational interviewing is a key component of that. It's how you can get people to come on side and lose weight and stop smoking without them feeling as though they're being coerced into doing that. So now we have a team here, this the inflammatory skin disease team, because of course we have patients on biologics for hidradenitis suppurativa and eczema. And you can see it's everything. You have a nurse consultant, every way down to nurses in training. But they are a crucial component of what we do. And the way it works is that biologics patients are managed mainly by weekly psoriasis clinic with the nurses managing as well. There's a monthly psoriasis and psoriatic arthritis clinic for difficult cases. And then every 2 weeks, there's an MDT, multidisciplinary team meeting. And really the main problems that arise as patients who have psoriasis and cancer on biologics, or they have an infection, or they have disease that's not responding to the usual therapies. What about research? Well, the dermatopharmacology unit, the clinical trials unit, is, as I mentioned, recruits mainly from that psoriasis clinic. We've recruited patients to over 300 clinical trials. We have a big MRC stratified medicine program called SORT. You would have heard of BADBIR, which is our pharmacovigilance register that we set up and ran nationally from Manchester. And there's a nurse in the clinic whose her main role is to recruit and follow up patients on BADBIR. And we have over 450 publications that have come out of the psoriasis service. And this is bad beer. It's now the world leading pharmacovigilance register. And this across the UK, it's nursing and nursing support that makes this so successful. And we can look at patients who are on conventional treatments such as methotrexate compared with biologics. And now we've started to move out of the hospital. We've moved, we have a rapid access clinic in the community, as you see here, which is GP surgery. And this is where patients are seen very early in their disease course, rather than having to wait a long time to be seen. They're actually seen within just a few months of their diagnosis of psoriasis. And this is staffed by a dermatologist and a nurse and a psychologist. And what we found in the first study that we did is that we're picking up patients who already have quite extensive disease. We're picking up new hypertension, new hypercholesterolemia, picking up newly diagnosed anxiety and depression, and about 1 in 5 have symptoms or signs, which means they probably have psoriatic arthritis. And training, well, we're training not just the patients about understanding more about psoriasis, but also public awareness. We have something called a shout out that the nurses participate in. We go around Manchester and each day talking about what psoriasis is and what it isn't, and so the general public understand that. And then we have now, working with the IPC, we are reaching out overseas, and through a charity called the Burma Skincare Initiative, we've had dermatology nurses from the UK teaching dermatology nurses in Myanmar, Burma, how to manage psoriasis. And those of you who are interested in psoriasis, we have a big study, a big congress coming up in about 4 weeks' time that the IPC are very heavily involved with, called Psoriasis Routine Clinic, and there's still time to register for that. So I'll stop there, and happy to take any questions if we've got time. Thank you.
Thank you very, very much, Chris, for this very interesting walk through history. It was very nice to see where we come from, or you come from, and how it's now evolving even internationally. I don't know, do we have any questions from the audience? You can put them in the Q&A box, or you can put on your audio if you want to share something with us. I don't see any questions directly. I was very triggered by the part on the PSOWELL study, and when you zoomed into the lifestyle part, because we had a very interesting talk of Chris Bundy at the EADV Congress, and of course she was a lead in the study, and she's also very motivated. But my question was, for you, is there any ideal model? And what I mean with model is, of course, you have a part is task shifting, for example, the prescribing, the follow-up of biological patients, but you also have a part of complementary tasks like education, lifestyle educations for patients. I think nurses indeed also here in Belgium, we see this as a complementary task next to the work that physicians are doing. But so what's the ideal model? And then do you feel the pressure of waiting times? Because I think pressure of waiting times, shorter consultations times, means that sometimes the complementary tasks are under pressure. How is that going in the UK?
Well, that's a great question. And of course, you know, doctors and the clinics in the UK, same as a lot of patients around the world, there's a lot of time pressure. But just because there's time pressure doesn't mean that you should be avoiding interrogating the patients further about, you know, are they happy with their disease control, and entering into the realms about asking about depression, asking about anxiety, starting the journey about the conversation about weight loss and diet. And, you know, it's not going to happen in one consultation, but it's a stepwise approach. But it can be, that's something that the psychologists such as Christine Bundy taught us, that you can do this in bite-sized pieces. But the key step is to actually embrace it in the first instance and actually enter into the conversation. Because as you all know, everyone on this call will know, people with psoriasis tend to be less forthcoming about their problems. And you've got to, you know, tease it out of them. You know, they're going to say, yeah, things are fine, when actually they're not fine. And I think it's our role is to listen to them and to bring that out and make them feel that it's important to let us know how they feel. So you're right. Thank you.
Thank you. So I see one question from Singapore, from Edmund Lau, who asks, may I know the subsidy model in UK for psoriasis? So the
The
reimbursement.
subsidy model, is that the question?
Yeah.
Well, of course, in the UK, we have a national health service. So these patients are all treated, it's free at the point of contact. So they don't pay for their drugs, they don't pay for their outpatient appointments. There is some resource that flows to some of the specialist units, and we do have that in Manchester, as they do at St John's Institute of Dermatology in London, that's for sure, and that's the other big psoriasis clinic in the UK in London. But it's actually hard to get that funding, I agree. And if we were having to do that as a funded model, that would be very difficult. But you may know we've got a new government in now in the UK, and they're looking very much more towards this sort of community care aspects of psoriasis. And my goal is to try and move psoriasis out into the community and have task sharing where you can train nurses and GPs to manage psoriasis in the community, and maybe even prescribe biologics.